I want to apologize for last few days ago, the mishap with the internet. Sorry about that. All right, so we're going to continue in the lecture and then hopefully finish and then start off another. Just because we're kind of like running against time, just given that the exams are going to be earlier. I received an email from your group, one of the group leaders yesterday, requesting that we delete a lecture or two. So I'll work on that. All right. So I believe we got to this point here, which is types of psychological tests. And so there's kind of three categories. Types of tests where the subject performs a task. So you ask them to do something. Those tests where it involves observation of behavior. Okay, obviously within a particular context, usually using some kind of a tool. And then you have self-report measures, which are like checklists. So how are they used as a psychological diagnosis? All right. So what is, again, so a psychological diagnosis or assessment is a process of searching for data that are necessary for decisions or actions and obviously lead to changes in human life. Based on the diagnosis, you're going to do counseling, you're going to do therapy, you're going to do an intervention of some sort, you're going to recommend something. So it's all based on your psychological diagnosis. Psychological tests are instruments that are used for the purpose of psychological diagnosis, and they serve to obtain information about behavior that's necessary for psychological diagnosis. Now, when we do an assessment, so I'm doing a history, for example. Like yesterday in my clinic, I have students, I have residents. And so the process starts with just taking a history because it guides you as to where the problem could be. And accordingly, psychological tests will be chosen, all right? So it's really based on what you think the problem is. So it's really essential, no matter how far you are in your career, is to take the time to take a good history. So the Wechsler Adult Intelligence Scale is the standard assessment tool, right? So this is the standard assessment of intelligence. It was developed by somebody called David Wechsler. It's the most widely used test. We also use it in children, and it's called the WISC. So the WAIS is for adults, the WISC is for children. Okay, so children and preschoolers, okay? And the WAIS consists of 11 subtests. And it doesn't just give you an overall intelligence, but it gives you scores on subtests. So again, if somebody's IQ is, let's say 100, the number in itself is not of as much value as are the actual scores on the subtests. And the reason for that is some of these subtests give you an indication of certain strengths or weaknesses that you can actually tap into and improve, right? So it helps us in diagnosing different problems. For example, low verbal comprehension score combined with high scores on other subtests can indicate like a reading or language disability. So these are the verbal and performance tests on the WAIS. So there is 6 verbal and 5 performance. I'm going to give you an overview just of them. So again, remember that these tests are standardized. So a person is compared to other people of their same age, obviously, and culture, all right? And these tests are timed, okay? And the reason that they are timed is, again, to make sure that the person is within the average range. So if the average, let's say 15 or 16-year-old, 20-year-old can do a particular test in, let's say, whatever, depending on the time set for these tests, let's say 120 seconds, okay, that becomes the average. And so if someone comes and does the same test and scores really well, but it takes them 3 or 4 minutes, okay, so obviously that person is delayed in that subtest, okay. Now the WAIS in terms of cutoff age is from the age of 18 onwards, all right? So adults from the age of 18 onwards are tested using the WAIS. Children, so 18 or 17 and below, we use the Wixler, the whisk, okay? So when you look at vocabulary, you're really testing the person's fund of word knowledge, okay? How many words does this person know and understand? Similarities is, again, as simple as how are an apple and orange similar, how are a cat and a dog similar. So if someone tells you the apple and the orange are round, so that's a very concrete way of looking at it versus they are fruits. And how are a dog and a cat similar? So if someone says they have 4 legs, that's, you know, a level versus they are mammals. So again, both answers correct. However, it just tells you something about the person's probably level of education or intelligence. And again, all answers that are possible are scored, okay? Or let's say for every one of these tests, there are a set of correct answers based on standards. And if the person does not get any of these, then their score is obviously going to be on the lower side. Arithmetic is one of the tests of like raw intelligence. So because it really doesn't need a lot about, you know, of cultural exposure or sophistication. So it's really your very basic raw like machine brain. And so again, based on your level and age, the digit span is one of the things we use that really helps us with people with ADHD. So if someone scores low on digit span, it's some indicator of their attention. So what happens is they're given a set of numbers and they're asked to repeat them in order, like forward, and then sometime down the test, they will be asked to remember these numbers and then say them backwards. Okay, so it's the sort of working memory. If you remember when we talked about ADHD, so if someone gives you a set of numbers and if you're not really paying attention, you're not going to grasp these numbers. So it's a test of your immediate attention. Information is basically like how much do you know about different things in life. And so when people score lower on general information, it just indicates that maybe there's not enough stimulation in the environment. So these people maybe don't really listen to the news, don't really read, they're not well informed. And so this is one of the areas that you can actually improve by informing the person or parents, depending on the age. Well, you know, this is an area that you can actually, you know, score better on if you improve your general fund of information. In comprehension, as the word indicates, so you know, people are given pieces of information and their comprehension of it is tested. Okay, so these are all verbal skills, right? So often we do face people who have, let's say, neurological problems where it's impairment of their verbal skills. So aphasias of different sorts, or children who are delayed in their language and speech. And so again, taking a good history and informing the psychologist, you know, that we have an impairment of some sort, and so they can tailor the tests for the problem. And again, there are tests of nonverbal ability, so not even the Wixler at all, tests of nonverbal for those, you know, specific deficiencies. With the performance, so again, not verbal, so it's more about like your visual, spatial, your ability to pick up on details. So in picture completion, you're given a set of pictures and you're sort of asked to kind of see what is missing. So maybe it's a picture of a person missing a hand, as simple as that, and obviously more complex as, you know, as a person's age is older. So looking at what's missing in a picture. The digit symbol coding. So there are a number of digits, so like, for example, 1 to 9, and each number is matched with a symbol, all right? So number 1 is matched with a particular symbol, and the person is given that sort of code. And then they're given a set of digits that are without a symbol, and they're supposed to quickly, you know, look up and see, okay, number 2 goes with what symbol, and they're supposed to draw the symbol. So this is really visual motor. It's about speed, it's about attention, okay? Block design, it starts off from very simple to very complex. So a person is shown a particular design with a block, and they're asked to imitate or repeat the same, and it starts from very simple to more complex. Again, it's visual spatial kind of problem solving, frontal lobe kind of function. Picture arrangement, they're given a set of cards, and they're asked to arrange them in a way where it actually makes sense and you can tell a story. So you can imagine here that it could be extremely variable, but then there is a standard. How you arrange the pictures to tell a story. It could also tell about your state of mental well-being. So if somebody is depressed and how they see the world, or if somebody's manic and completely unable to arrange pictures. Symbol search is again, a person's given a set of symbols, and on one part of the page, so for example, like 5 symbols, and then on the left side of the page, they're given 2 symbols, and they were asked to see if these 2 exist in the 5. And so they would say yes or no, like there's a square that says yes or no. So they want to make sure that these 2 symbols on the left exist in the 5 symbols on the right, like if there's a match. And so again, it goes on from, again, depending on how much time a person takes to make that recognition. So a lot of it is visual motor, visual spatial. Okay. Now the Stanford Binet, so it says here 4, but there's a 5 now. So that's another test of intelligence. And it looks at sort of certain domains. So it looks at verbal reasoning, which includes vocabulary, comprehension, absurdities. I don't know if does anyone know what absurdities means? And verbal relations. What is absurdities? What do you think that means? If something's absurd, does anyone know what that means? Okay, so absurdities is like if something really like stands out. So if something's absurd, it's like it's ridiculous, so it doesn't really make sense. So kind of figuring out if things are, make sense, don't make sense. So kind of picking up on that. The second is looking at abstract visual reasoning. So it looks at pattern analysis, copying, matrices, paper folding, and cutting. So visual motor. Quantitative reasoning, which is looking at it's a quantitative test, so look at numbers, equation building. Short-term memory includes memory for sentences, digits, and objects. And so then all of these areas are combined and you get a score. So the use and abuse of psychological tests, okay. How do you think you can abuse these tests? We obviously know that we can use them, but how can we abuse these tests? What do you think?
Pardon me, doctor, we cannot really see our chat bar. The icon for the chat is gone. We cannot participate except with the voice.
Oh, Dr. Fariha. Yeah, because I figured
there is nothing that says that chat is not allowed.
Okay, so, but I don't see it either, so.
I'm not sure why.
Okay, so, all right, so thank you for letting me know so that I'm not asking and not getting responses. Thank you so much. So the use and abuse of psychological tests, obviously, these are very confidential assessments. They can kind of change people's futures, lives. And so usually when someone is referred for an assessment, let's talk about kids, school refers a child for an assessment. And accordingly, they may dismiss this child or not based on this assessment, okay? Who owns the assessment? Is it the school or is it the parent? Okay, so the answer is the parent because they are the legal guardians of this child. And so what we do is we do the assessment, we give it to the parents, and then it's up to them to share with the school, or that they sign a consent that we can share it with the school. All right, so you have to be very careful. Also medical legal, like if someone is referred for an assessment for competency, for example, with regards to issues at work, okay? So if a person does get the assessment, again, there's a consent format, right? So these kind of tests, we don't just like readily send off to whoever. And if someone calls to ask about results, again, we don't share readily with whoever. I mean, there has to be a very strict, consent to sharing of information, okay? And so again, because they are useful tools, but also, like I said, they could completely change a person. I mean, people can be dismissed from their jobs, kicked out of school based on what you write in the report. Okay. So here, again, this is not going to be included in your exam. So principles of test construction. So from this slide, this is not included because it's all about, statistics, which you guys are, I'm sure experts at. But I'm just going to go over it and I'll tell you until where to stop. So those slides that are not going to be included. So starting here is not included. So reliability, validity, and standardization. So these are essential when we talk about assessment tools and how they're standardized. Okay. So standardization, reliability, validity. Okay. I'm not going to go over that so you guys know it really well. So those slides are not included. Starting here is where, back on included. Okay. So extremes of intelligence. We mentioned earlier in the lecture about how IQ is sort of divided, all right? So that the average IQ is from around 90 to 110. It's not a percentage, it's a number, okay? And that below, from 70 to 90, you're talking about people with borderline IQ, and that means that they're slow learner. They're not disabled, but they're just slower. So they kind of need to be pushed. Below 70 is, people with intellectual disability. So, okay, so this is the table. So from 50 to 70, you're talking about mild intellectual disability. And what that means is that this person can go up to like 6th grade, but they kind of need focus on vocational or social skills. So they can kind of do jobs with vocational help, okay? So does that mean that if somebody is mildly intellectually disabled, can they get into medical school, for example? So the answer is no, okay? Because their abilities will not get them that far. With moderate intellectual disability, you're talking about an IQ of 35 to 50, and they pretty much maximum get to 2nd grade, and then they're involved in more like labor work. And again, you have to be careful because labor work, operating machinery, it needs a lot of coordination and problem solving. So it's not, not somebody that's going to be driving anything or handling something that could be dangerous. Severe and profound, honestly, I've not seen, particularly profound. I don't think I've ever seen anyone with profound intellectual disability. And probably the reason being is that usually these people are born with congenital syndromes and may not make it far in terms of like, maybe they have a lot of complications that are organic. But again, people with an IQ of 20 to 35 are really very difficult to train, okay? And obviously cannot be independent in their living, and usually are in sort of homes for care. So they're in homes for care. What about extreme, like the higher extreme? So people that are gifted, okay? If you remember Piaget, so by age 7, he was observing birds, fossils, and by age 15, he published articles. So 3 to 5% of children are gifted, and so they too will need special programs. So the extreme ends, if you have a bell curve, so the average is under the bell, under the diagram, and then you have the extremes of 3 to 5% both ways of either its intellectual disability or being gifted. So the stability of the test scores increases with age. By age 4, there's some fluctuation. By age 7, scores are pretty stable and consistent. And again, this is school entry. So by age 7, 6, 7, when you enter grade 1, most of your intelligence, let's say parameters, are pretty much fairly stable and consistent. And so begins the process of learning, okay, at school. Obviously, this can be affected by external factors, whether it's injuries or tumors or epilepsy. So these organic conditions will affect intelligence. You know, I've seen kids where brain tumor removed, and then it's the effect of chemoradiotherapy that affects their overall intelligence. But then can you spare, like, would you say that I'm not going to give them chemoradio because I want to preserve their overall intelligence? Obviously not, because it's life-saving, but for sure over years and sort of technology, the areas of the brain that are exposed to radiation are now way more focused and limited. So it's not like you're exposing the entire brain, it's just very focused. So again, the deficits post-treatment are a lot more localized. Okay. So when you want to assess psychological disorders and symptoms, okay, so pretty much the purpose of the assessment is because you want to understand the person, you want to predict their behavior, you want to plan their treatment, and obviously you want to, you know, evaluate the treatment outcome. And so it's kind of like a funnel, multimodal in approach. You start kind of pretty wide and you go narrow. All right. When we do a behavioral assessment, we're like focusing on the here and now. So someone comes because there's a behavioral problem, okay? Like yesterday, I saw this child, 10-year-old, who about 2.5 years ago started to, you know, become imbalanced in their walking. So they're just not very steady on their feet. They were taken and obviously imaging and the whole 9 yards. And diagnosed as having a mitochondrial disease, all right? And so then they started to receive all sorts of treatments, and he was doing fine. But about a year ago, there was an absolute change in behavior. So this kid started to have nightmares. They started to lose language skills. So he wasn't very clear in how he was talking. He started to have hallucinations. So like I said, fears, difficulty with sleep. Even his behavior was very disorganized. Self-help skills kind of went down, right? And so he was labeled as psychiatric and, you know, again, searching for treatments. But again, you know, it's not about the treatment as much as to try and understand what is the problem. You know, why is this child behaving? So we're focusing on the here and now, okay? Is it related to something that's going on in their environment? Is it related to something that's going on with them internally? And so I was trying yesterday to identify the target behaviors. Okay, what is it that they're actually observing? Because again, it's really important to narrow down and get a really good history. And you focus on the antecedents, the behaviors, and the consequences. So there's a particular behavior. So what happens before that leads up to it? And then what do people do with the behavior? So if someone's acting out, okay, or having a tantrum or is losing their temper, okay, so they have anger management issues in adults, okay? So you don't want to just deal with, okay, they're angry and what are we going to do about it? You want to understand what led to it, especially with, again, the population that I see where there's a lot of just global developmental delay. And so these kids are not very expressive, right? They're not going to come and tell you, I'm really upset because, you know, 1, 2, 3, they are going to act out. So they're going to be aggressive, screaming, hitting, peeing on themselves, whatever it is, that's the behavior. So you want to figure out what led to it, because that's going to help you, you know, choose or make a treatment plan. So anyways, for the kid that we saw yesterday, the mom says that about, you know, 6 weeks ago, he started to improve, all right? And that about a month ago, he started to have these, like, he'd wake up in the middle of the night, he'd be screaming and he's really afraid, right? So no onset symptom, however, overall improvement in that he started to become more organized. His language, again, he's more expressive. So something's working and something's not working, all right? So what I do is I pick up the phone and I call their neurologist, because that seems like the most logical thing to do, because I'm thinking, do I medicate this child because of their behavior and their fear, or do I wait, okay? So I spoke to the neurologist, and so we agreed that just given, you know, that there's this slight improvement, that I would prefer to wait, and that maybe we should EEG this child. Maybe these sort of nighttime episodes are some kind of epilepsy, right? And so that's exactly what we did. So he's booked for an MRI and EEG. We're going to wait on, not jump in and medicate this child, and we'll see him in about 6 to 8 weeks after his imaging and EEG have been done, right? So again, I was just telling my residents yesterday, sometimes less is more, okay? We all have this tendency to want to kind of jump in and save the day and rescue and make the change. But honestly, sometimes just waiting is the best treatment that you can do. Because again, obviously you're waiting with an objective. It's not like you're waiting because you don't know what you're doing or you don't know what to do or you're lost. I mean, that would be a problem. But waiting because you have a plan, okay, that's communicated to other members of the patient's team as well as the parents. Okay, so it's a sensible plan, okay? So when you want to observe behavior and you do a behavioral assessment, so this could be either formal or informal. And it's informal if like a mental state exam. So you're sitting and you're talking to somebody and you're not really telling them that I am doing now a mental state exam. Okay, it's not like you're prepping them for it. You're observing, and based on your observation, you're going to come up with some kind of a conclusion. Or it's formal because the person's coming in for a specific type of behavioral assessment. It could be self-monitoring versus, other people observing. So self-monitoring, for example, I can give a teenager a mood chart because I want her to monitor her mood over the next week until I see her. So highs and lows, time of day, incidents that happen. So it's a self-monitoring kind of assessment. And so there is an issue again with using direct observation is a problem of reactivity. Like again, turning in terms of threshold, like what is my threshold for normal or abnormal? So I could see again, based on experience, a behavior, that's again, I wouldn't make much of a big deal of it versus a resident who's just starting. So again, yesterday, an autistic girl who I've been seeing for like 10 years, she has these really interesting carré form hand movements, like these dancing movements of her hands. And so again, the interpretation of that, is this chorea, is this not? But obviously, this girl was already referred, assessed by movement disorders. But again, how do you react to something like that? Do you just take it lightly? Do you actually go ahead and make referrals? So also something for you to note. Okay. So antecedents are things that lead up to a behavior, and then, it's the consequences after. So imagine this child has a tantrum every time they do, they're, punished. They're on the naughty chair or whatever, time out. Is that going to help? Maybe, but it'd be a lot more helpful if we could figure out like what leads to that, So I had this patient where, again, globally developmentally delayed with autism spectrum. And when he'd come home from school, he'd just scream, all right? So absolutely like go into like a complete fit, right? It took a while, and then mom was like, and she'd prepare his lunch, and then he'd eat, and then he'd settle, all right? So then we figured out this kid has a really hard time waiting when he's hungry. So the antecedent here was like, the hunger really drives him to become aggressive, all right? So we changed things so that when he come home, food is ready. And so then this behavior was abolished, all right? It's as simple as that, but again, sometimes it's a lot more complex, and usually it's a lot more complex than, if the child is hungry or the person is upset or whatever. But I'm just saying that it's looking at these small things. I have this other really interesting kid, also autistic, where at school, he just would have a fit in the bathroom. Like he would not enter the bathroom. It's just really difficult for him. All right. So they're like, okay, is he being abused? Is he, whatever? And it was as simple as at home, they have the Arabic bathrooms, the hole in the ground. In school, it was a regular bathroom. So it was so different for him. Like it's just not the same look, not the same anything. So, and he's autistic, right? So the reason he was freaking out is just the bathrooms are different. So again, antecedent behavior, and so then you can deal with it and figure out how you can, accommodate this child. Right. So the domains of assessment, we have objective tests and we have projective tests. Right. So projective tests, they really look at personality, because usually what happens is people they project aspects of their personality onto an ambiguous stimulus. So something that's a blank paper. All right. Some of us will, again, you look at a painting and your interpretation of it, especially these like existential, kind of like dots on a paper that you don't understand the art behind it. But I mean, again, the interpretation of it depends on what you see, and what you see depends on who you are. Okay, so the projective tests really kind of look at psychoanalysis. All right, it's kind of goes back to psychoanalysis. Remember Freud? There's a high degree of inference in scoring and interpretation. And the examples here, again, the very famous are the Rorschach ink block tests and the TAT, the thematic apperception test. So the Rorschach, and we'll talk about that. So that's kind of the most famous. So that's when you show somebody like these blank, like pictures of just black, and then people interpret it based on what they see. Do I see a butterfly? Do I see an elephant? Okay, so here it's again, reliability and validity data tend to be mixed, but it's a real good, I mean, it is still something that's being used as an assessment of personality. We'll talk about the projective tests in a bit. So the trait perspective. So Allport describe personality in the terms of fundamental traits. Okay, so kind of your characteristic behaviors, your conscious motives, right? So we all have traits. This is different than having a personality disorder, right? So I think you did take personality disorders with Dr. Ali. So a disorder obviously is dysfunction, so an impairment of function. But some of us have traits, okay, that are not the best, okay, but they don't impair our function. But this is your traits are kind of like who you are, right? So he was concerned less with explaining them and more with describing them. That was his focus, right? By placing people on these several trait dimensions simultaneously, they can kind of describe countless individual kind of variations. So there's almost 18,000 traits that are used to describe people. Okay. So these psychologists, these British psychologists, they believe that normal variations can be reduced to kind of 2 or 3 dimensions. So they kind of plot these traits onto kind of a grid with 2 ends. So it's kind of like a X and Y axes, all right? And they believe that these factors are genetically influenced, right? So they're saying that, there's this extreme end of introversion versus extroversion, unstable being stable, all right? Obviously, this is the healthy quadrant, to be stable and an extrovert versus being an introvert and unstable. So in this upper quadrant here are people that are moody, anxious, rigid, pessimistic, reserved, unsociable, and quiet. Unstable and extroverted, and people are like kind of restless, aggressive, impulsive, active. Here you have people that are kind of passive, careful, thoughtful, even-tempered, and calm. So not too bad. Okay, so kind of like choice number 1, probably choice number 2, because both are on the stable end. So you want to be on the stable end. Again, is this something that you can choose to be? No, it's not. This is just who you are. So maybe you want to think about yourselves. Where do you fit? The extroverted, stable. So people are social, outgoing, talkative, responsive, easygoing, lively, carefree, and more leaders. And so you will find that people from this group tend to hang out with people from this group because this is a lot of energy, right? Sometimes a bit too much energy, but they tend to attract the group. Okay. How do you assess traits? Okay. So we use objective tests because they're higher in terms of reliability and validity. And the test stimuli are minimally ambiguous, all right? And they require minimal inference and scoring. So you don't have to, they're a lot more standardized. They're a lot more sort of stable in terms of inter-rater reliability, right? So the objective personality test, the one that is most known is the MMPI, which is the Minnesota Multiphasic Personality Inventory. There's over 549 items, true or false, okay, extensive reliability and validity, as well as a lot of normative database. And then we talked about already the objective intelligence tests that we've covered. So the MMPI questions that, these are example questions, okay? So we said there's 549 questions, true or false. And these are then scored very valid and very reliable. So when a sample of no one seems to understand me, true or false, I get all the sympathy I should, true or false. I like poetry, true or false. Nothing in the newspaper interests me except comics, okay, true or false, okay. But again, some of us may answer questions because we want to give like a good impression. And so we may answer things as yes when they are really no, because we want to like be more positive, okay. But interestingly, they have these kind of, let's say, test questions, all right. So some may answer questions to give this high desirable response, but they will score high on the lie scale. Okay, so this is it assesses faking responses. Okay, so for example, I get angry sometimes if someone puts that as false. That's kind of taken as a lie because we all get angry sometimes. So it's really false to say that you don't. Okay, so they have these questions in these 549 that are meant to kind of pick up on if you're lying or not. Okay, so this because it's so objective and it's become so popular, and so it's been translated into more than 100 languages. So the Big Five is another one that you'll probably hear of. And so although these dimensions that were described by these British psychologists are important, but they can be limited. And so someone came along and expanded and they said there's a set of factors called the Big Five, and that was seen as better. It's kind of the winning test in personality lottery, if you will, and it's the best approximation of basic trait dimensions. So the Big Five. So here you have a trait dimension, so something like conscientiousness. So conscientiousness is like, I'm not sure how to explain it in Arabic, but what it is just kind of your self-assertiveness or your self-drive. Let's say it's your self-drive, all right? And are you organized? That's one end versus disorganized. Are you careful versus careless? Are you disciplined versus impulsive? So a conscientious person is someone who's very disciplined internally, okay? They're pretty careful and they're pretty organized. So that's, kind of the end of it. And then the extreme end would be somebody who's just careless, impulsive, and disorganized, okay? The other dimension is agreeableness. So on one end is people that are soft-hearted versus people that are ruthless, which is like heartless. Somebody who's trusting versus suspicious, someone who's helpful versus uncooperative. Another trait dimension is neuroticism. So somebody who's calm versus anxious, secure versus insecure, self-satisfied versus self-pitying. Openness, okay? Somebody who's imaginative, all right? So kind of like dreamy versus someone who's really practical. Somebody who likes variety versus routine. Somebody who's very independent versus somebody who's very conforming. So conforming is somebody who's like, who goes by the book, doesn't really want to step outside of the box. So again, it's extreme ends of one trait. And the last is extroversion. So again, somebody who's very social versus somebody who's not, somebody who's just very fun-loving versus somebody who is not, somebody who's affectionate versus somebody who's less so, okay? And so it's kind of summarized into canoe. So that's for you to remember. Okay, so how stable are these traits? Okay, so they're quite stable. They could kind of vary somehow in adulthood, all right? But then eventually they are stable. Some could rise with increased age. So as you get older and wiser, okay? So conscientiousness may increase. So your sense of self-discipline and sort of organization and agreeableness. So these tend to kind of increase maybe when, as you get older. They are heritable. Do they predict other personal attributes? Okay. So if you're somebody who is, on one end in more than one trait, likely you're going to be on that same end in other traits as well. So they can predict your other personal attributes as well. So going to projective personality tests, okay, so here they use very unstructured and ambiguous test stimuli. So it's not structured, okay? The basic assumption is when you're confronted with something that's vague, a vague stimulus, all right, people's responses are going to be very much based on their internalized sort of world. So their internal world is going to be projected because the stimulus is so vague, all right? Test stimuli are standardized. So the stimuli that you're using are standardized. So you're going to give the same ink blot to different people. It's the same one. The interpretation is going to be different based on, what's this person's internal world. So the Rorschach, and I'm sure you've seen this in movies. So you have 10 plates with ink blots on them. So it's like a blot of ink, all right? So the plates are presented to the patient one at a time, and their response is recorded verbatim. So, you show them something and they're like, gonna say elephant, witch, butterfly, okay? Whatever they say, you jot down, okay? And there is a special scoring system. And obviously it's used to assess things like psychosis, depression, anxiety, suicidality. And again, if someone's really depressed and suicidal, everything is just very bleak. It's not going to be optimistic what they see. They're going to just be seeing very negative things, okay? The TAT, so it's 20 cards with pictures on them. Some are age and gender specific. Pictures vary in content, right? They may contain one or more characters with different degrees of ambiguity, all right? The patient is asked to construct a story with a beginning, middle, and end based on the stimulus card. And the basic assumption is that persons really project their personality into the story. So in the story, it is them, right? Scoring is not standardized, right? So why do we do it? So if it's not a standardized test, why do we do it? So a lot of times when you have patients that are complex, all right, you want to do as much testing as you can in order to help you find direction, okay? It's not always as simple as just, major depression and that's it. You want to sort of try to figure them out more, but it can give you information about current themes, mood state, conflict, and interpersonal relationships. So it can help somehow, to give you a bit of a better clinical picture. So the psychological testing and neuropsychology, all right? So we have people, our colleagues in psychology, they're specialized and subspecialized, okay? So our colleagues in neuropsychology, have very focused patient population. They assess a broad range of skill and abilities. Their goal here is really to understand brain behavior relations. They look at people's assets and deficits, and some of the sort of batteries they use include the Luria, Nebraska, and the Halstead-Reitman batteries. So these are specific batteries that are used by neuropsychologists. And we say there's an overlap with intelligence tests because part of a neuropsychological testing is an IQ assessment. So it's sort of within the range of neuropsych, they also do these IQ tests, okay? So false positive is when you say that someone has a brain problem, but they do not, okay? Or saying it's negative that they have a brain, saying that they don't have. So either that they do or don't, sometimes it can happen. But the beauty of neuropsych testing is that it's kind of like a map. So what our colleagues do is they attend these meetings with neurosurgery because you want to map the abilities to the deficits that are seen in imaging, okay? And it's a really beautiful combination when, on imaging, you see a deficiency or a problem in a certain area, and the neuropsychologist will then complement that by saying, after testing that, areas of deficit correlate entirely with that area, plus minus other areas. And like I said, again, sometimes Imaging may be normal, but it doesn't mean that function is normal. All right, so other tests and methods. So again, complementary. So we look at sleep studies, we look at EEG. So these complement our cognitive assessments and our neuropsych. And like I said, you know, imaging, CTs, MRIs, and PET scans. So this is the end of this lecture. We're going to move on to the next. So again, I feel really terrible that I'm not getting any questions. Maybe by email. I'm not really sure.
Doctor, the
Yes.
chat is disabled, so we can't message on it.
Yeah, I know somebody said earlier. I'm not sure why that is. So I'm just suggesting that if you guys have an issue, to email me collectively, please. Like, I don't want to get like 180 emails. All right. So if you know, groups of you just have like a number of questions in one email or two, that would be great, because that would be easier for me to respond to versus you know, everybody having individual questions. I hope that's reasonable. I hope, because I mean, I'm not going to be having time to you know, kind of attend to that. I'm just going to have to answer the hospital, so I will leave you guys for a minute, okay? To intellectual disability as a lecture. You're probably not going to get it anywhere else. Like, this is going to be it. I will keep this lecture for the future as a reference when you're in pediatrics and whatnot. We talked very briefly in the previous one about like the grid where we put mild, moderate, and you know, severe and profound, where there is a number. There's been like an update in how intellectual disability is, like, let's say, understood or discussed. And so definitions again, in the past it was mental retardation or mentally retarded. Obviously these have been removed because they're not politically correct, emotionally accepted to kind of label someone as being mentally retarded, right? But unfortunately, like I had this patient yesterday in the clinic, and so the girl's IQ is in a mild intellectual range, so her IQ is around 65, all right? And so the psychologist had uploaded her assessment. Sorry, had uploaded her assessment onto the like our what's it called, the system in the hospital, so our chart viewer, and the mom kind of knew what the problem was, but not really. So she's like, you know what, my daughter has a mild problem. So we had the daughter go out because she's 14, and I then try to understand, like, you know, what is your understanding of mild, you know, and so she's like takhalluf, and so the word is really, so we said, like, we don't say takhalluf, we don't say it's retardation, we just say ta'akhur, we just say delay, right? So there's a delay in this person's cognitive abilities, does not match their age, okay? So in 2010, mental retardation was replaced with intellectual disability or individual with an intellectual disability. In 2007, okay, there's the American Association. Again, the American Association of Mental Retardation has been around since 1910, but it was renamed. Okay, so it's now named the American Association on Intellectual and Developmental Disabilities. And in DSM-5, intellectual disability has replaced mental retardation for the first time in DSM history. And the severity is now classified based on adaptive functioning rather than IQ. Okay. So that's kind of how you look at people in terms of their adaptive functioning, but we still, we still use numbers because it kind of helps us also understand, what are this person's strengths and their limitations. Okay. There's obviously a greater recognition now of making a diagnosis. And the reason is you can really change a person's life to the better by understanding their abilities. Okay, so it's not really their disabilities as much as what are they able to do. Okay, that's how we look at it. So this person is able to do these things, so let's empower them. Let's try to accommodate so that they can learn, they can work based on their abilities. Okay, so it's kind of it's like a major shift in how you look at people with difficulties. All right, so these adaptive functionings are three, it's a kind of a triangle. So it's conceptual, social, and practical. So looking at people from these three domains. So your conceptual domain is things like your language, your reading, writing, math, reasoning, knowledge, memory. So again, these are important for you guys to know. When I say conceptual abilities, what am I talking about? Social abilities are things like empathy. Okay, so that's a really hard one because empathy is something that should be like innate. We're kind of born as empathic creatures, but it's really difficult and maybe limited for people based on their overall sort of adaptive functioning. So empathy, social judgment, interpersonal communication, the ability to follow rules, ability to make and retain friendships. Okay, and again, this is a huge area of struggle for a lot of people. How do you make friends? Okay, so I've made friends, but then how do I keep them? How do I retain them? So again, your ability and your social IQ. Remember I told you last time that some people have really high overall intelligence, but can score really poorly or low on their social intelligence. So they're not like socially smart. Okay, and that this is something that may require intervention, exposure, experience. It's something that you can improve. Okay, and then there's the practical domain, which is things like personal care, money management, job responsibility, recreational, organizing, school, work, other tasks. So these are the three domains. Okay. So intellectual disability is defined as significant limitations in intellectual functioning and adaptive behaviors, which includes the three that we've talked about: conceptual, social, and practical skills. And this obviously is originating prior to the age of 18. So the importance of a cutoff age is, again, for the purpose of identification of cases and for studies like, research. But again, we've seen somebody who is of normal intellect and then, post head injury, post whatever, intelligence has been affected. So all of these areas, conceptual, social, and practical, have been affected by their sort of imposed upon organic condition. So do you label them as being intellectually disabled? Okay. So the naming will be different, like the labeling will be different because this is a person who had just absolutely normal intellect, but it was an on top of issue that created a problem. So this American Academy of Intellectual Disabilities emphasizes that you have to look at strengths over limitations. You have to look at the community environment that is typical of their person and their culture. Okay, so you have to, again, look at culture in terms of understanding people, linguistic diversity and cultural differences in the way that people communicate, individual strengths, using personalized supports over a sustained period of time to improve their level of functioning. So things like individual educational plans, IEPs, I don't know if you ever heard of those, but those are really helpful when you have a child or a teenager with, you know, certain areas of like maladaptation, and so you want to like have them fit in mainstream school because they can, and so you have to kind of personalize the support in order to support them. Okay, so the American Association has kind of then divided support into levels. Okay, so people that are higher functioning, okay, so those that are mild intellectual disability, they will require very little intervention to function, except at times of stress. So people here will just need intermittent support. Those with more moderate intellectual disability will require additional support to navigate through everyday situations. So obviously more support. Those that have severe intellectual disability and profound, you're looking at extensive and pervasive support. So here you're talking about someone who relies around the clock on others to function. And here is someone who requires daily interventions and lifelong support to help them function in just activities of daily living. So the level of support will vary depending on the level of intellect. And obviously that makes sense. It's not like rocket science. So I want you guys to go through the diagnostic criteria, okay, to read through and to kind of match. So when we're looking at, here is somebody who has mild, okay, intellectual disability, all right? So this is 85% of intellectual disabilities will be in the mild range. So looking at kind of, you know, these conceptual and social domains and practical domains, you know, what are their areas of strengths, okay? So for example, for preschooler with mild intellectual disability, there may actually be no conceptual difference. You may not be able to tell them at all between them and just, you know, normally, other normal preschoolers. For school-age children and adults, there may be difficulties in the learning, okay, and some of the skills like reading and writing. So they start to have some areas of deficiency, all right? When you look at the social domain, here they may be a little bit more immature in their level of social interaction. And when you look at the practical domain, all right, they may function as age appropriate in their personal care, okay? They may need some support with complex daily living situations. Now compare that to somebody who is of moderate delay, all right? So as you read through, you will realize obviously there's going to be a lot more deficits as you go down, all right? So moderate, then obviously with the severe, a lot more areas of deficiency in these domains. So I do want you to read through these tables, please. Okay, and then the profound, again, because well, less than 1% of people with intellectual disability will have profound disability. So it's really extremely uncommon. And like I said, because a lot of these kids will have these syndromes that may not be life compatible. Okay, so how do you make a differential diagnosis? So you want to look at generally neurocognitive disorders, so that have co-occurring intellectual disabilities. So when we see a child with an intellectual disability, that's a presenting symptom. Often you want to find out why. Why does this child or why does this person have intellectual disability? There is a percentage of these kids or people where there's absolutely nothing. When you do all sorts of assessments, investigations, and there's just nothing. They don't have a syndrome. They don't have any chromosome problems. Their brain imaging is fine. And those are the ones that are like kind of hard to explain to the parents because there's nothing wrong. This child, there's absolutely nothing wrong with them, but they're intellectually disabled. Of course, like you may find that these kids also have developmental delays. So it's a package, all right? So they're a little bit delayed, maybe delayed in their walking, delayed in their talking, and obviously their cognition will be delayed, all right? There are people with specific learning or communication disorders, okay? And here, the impairment, again, is very specific. So somebody who has a speech and language delay may look like they're intellectually disabled because of their language problem. However, it's very isolated to their language. They're able to function, their activities of daily living are completely normal. People with autism, okay, a large percentage of them will also meet criteria for intellectual disability because they are comorbid at 70 to 75% of cases where they will also have intellectual disabilities. So the epidemiological studies indicate a rate of about 40 to 45% of people with you know, a combined type of a problem. So how do you assess intellectual adaptive functioning? So you have to do a comprehensive assessment of function. You assess their adaptive behavior, like how can they kind of adjust to, you know, certain situations. So this is a complex, I'm not going to ask you about this, all right? But this is just for FYI, all right? So these very complicated ways of looking at chromosomes and sequencing to look at the underlying genetic syndrome. So unless you're going to be somebody who's in genetics, this is just FYI. When you look at standardized intelligence tests, the ones that we've already discussed, like the Wechsler or the Stanford, these are of limited value in assessing people with severe and profound intellectual disabilities, okay? And the reason is that these people, kids or adults, cannot understand what you're asking them to do. So imagine if you're doing a performance subtest where you're giving this child or adult blocks and you want them to follow a pattern. So if somebody has severe and profound intellectual disability, they don't know what you're saying, they don't understand, okay? These tests are pretty rigid in how you administer them and how you score them. So they have very few test items for extreme ends of ability, all right? So even if you have somebody who's gifted, maybe these tests are not ideal, okay? These tests are ideal for the average population. So if you have individual items that include observation, so these may be more useful. So again, this is just FYI, all right? This is just for you to kind of go through. Just tells you that, shows you that there's like a million of tests out there that we use. It tells you about their strengths and limitations. I'm not going to ask you about this, okay? So it's just FYI. The same thing here. Remember we talked about Bailey's when we looked at when we were looking at cognitive function, all right? But again, this is another FYI. Another one of these FYI, just for you to know. So we have so many tests out there. Now the limiting factor is standardization and sort of culturally when you translate and you standardize. So some of these are not translated or standardized to our culture, okay? So depending on, sometimes people will use them with that in mind. Okay, so you're using it, but you know that it's not standardized. But again, you're trying to, you know, have a more comprehensive assessment, okay? Our colleagues in psychology are, you know, obviously trained to do all these types of tests. So again, who should communicate the diagnosis of intellectual disability? Okay, do you think it's the psychologist who does the assessment? Or is it you, the pediatrician, or the neurologist, or the neurosurgeon, or me, the child psychiatrist? So who should be the one to communicate? So obviously it should be the person who evaluates the patient. So because they're the one that kind of they've been with the patient through the assessment process. And so, you know, they've witnessed it, they've seen it, they've assessed the person, and they've written a report. Okay. The initial evaluation is usually very stressful. Again, you know, assessments of intellectual disability are usually done with children, okay? Because, you know, it's really very unlikely that you see somebody who's an adult who's never had an assessment in their life. That's extremely strange and unusual because, you know, we pick up these kids early on because they're either delayed in their speech, so there's something wrong, or they're starting to have difficulties at school, and so there's something wrong. Okay, so that's really when you get the referral to assess the child, or if there's a new onset of some sort of neurological disease and you just want to see if there's an impact on cognition. Okay, so yesterday again we saw the this young girl, trying to remember, I saw so many patients yesterday. I think she was around 9. Yeah, she's in grade 4. So a 9-year-old who was completely fine and normal until 5 months ago, where they noticed a gradual decline in her academic function and cognition. So the neurologist referred her because they could not find a reason. So they've done imaging, they've done everything. They're just waiting on the result of the lumbar puncture because maybe it's some autoimmune issue. But again, so she was also referred for a cognitive assessment because they just noticed her cognition was not as it used to be. So we're still trying to figure her out. We don't know what's wrong with her yet. Okay. So the initial evaluation is really stressful for parents when you refer their child for an assessment of their intelligence. So parents are really apprehensive because it's an assessment, it's a test. So they want their child to perform the best. And there's a lot to do with self-blame. You know, a lot of times parents blame themselves for their child's difficulty or disability. Maybe it is something I ate when I'm pregnant. Maybe it's because I was like fighting with my husband when I'm pregnant, that my child has a problem, you know, so there's a lot of that going on in terms of, you know, how parents think, and we address that. I mean, I address that, but obviously I'm not the one that's going to be breaking the news to parents about their child's level of intellect. The experience itself can greatly influence their willingness to seek and use resources. So it could be a great experience, like how the evaluator, you know, kind of accommodates the family and how they deal with the process to be great. And so it kind of encourages them, or it can be nasty. And then they're like, you know, it kind of stops there. The clinician should be providing very clear information about the testing and why it's being done, and also inquire about their expectations. So that's really important because we run into sort of difficulties, or let's say problems or conflicts when you have an expectation of a parent that was never touched upon. Like I saw this, he's now 20, a 20-year-old autistic young man. And so his mother with him yesterday was like, I want him to be referred to speech therapy because I want him to speak like normal people. Okay. So this is not a realistic expectation by any means, because he's autistic and he's also intellectually disabled, right? So if I were to just say, okay, yeah, sure, and refer this patient, I'm not doing them a service, because, you know, we're not talking about her expectations. So we talked a lot about it. There were tears. She was not, you know, she was very sad, but, you know, he's already 20. And so, you know, this information was delivered to her over the years by myself as well. So we've talked about this before. It's just interesting for my residents to see, because every time I have new residents, but it was something that we've already discussed. And so she has very unrealistic expectations that we have to address every time. So in presenting the results, you have to be very truthful, okay? So you can't sugarcoat information. So when you tell somebody who has a mild intellectual disability that your child just has a mild problem, that's not fair to them, because they walk out with this impression that there's not really much of an issue. The doctor said it's mild. And so mild means that maybe it's just going to go away. And that's not the case with intellectual disability, because these kids will never be okay. They will never have normal intellect. They will always have, you know, whatever degree of intellectual difficulty that they have. That's something that they're going to have to live with. And so when you deliver truthful information, obviously not in a harsh way, you know, empathic and accommodating, but truthful, because, you know, it helps them then plan for this child in terms of academics, future. Okay. Technical and diagnostic terms really should be used using very simple language. So you can't sit and talk about conceptual and domains and whatnot. It's too complex. You want to simplify. Okay. And again, when you communicate the results, it should really reflect the strengths as well as challenges. So it's not all about the child's difficulties or disabilities, but also looking at, these are their strengths. Let's really empower them. Let's focus on them. So when I see kids with mild intellectual disability that are really good at, like tasks, or like really good with their hands. So you tell parents, promote their visual spatial skills, because, that could be an area for the future. Or if they're really good at sports. So I remember in my residency, there was a young man with mild intellectual disability and ADHD, but he was just amazing at hockey. In Canada, it's hockey. And so he was able to get a scholarship to university just because of hockey. So, with his mild, again, disability, it was a college, so not a university. And it was really focused on, more like manual stuff, but the main highlight was his the sports. So you want to look at where their strengths are, invest in them. Okay, so the written report is usually given to the family, okay, with a lot of resources and referrals, and again, treatment recommendations that are appropriate. So intellectual disability is one of the most common disorders that affects kids under the age of 15. 30% more males are diagnosed, so we see it more in males. The ratio of male to female decreases as the IQ decreases. So if you're going to have more of the profound and severe intellectual disabilities, they may be more equal. Whereas if you're looking at more of the mild intellectual disability, we may be seen more in males. Prevalence of about 1 to 3% varies with age. Also, depending on how it's defined and the method of assessment used. Sometimes people will use adaptive scales. So if you go back to the pages where it just tells you about the tables of different scales. So one of the scales that's used is called the Vineland Adaptive Scale. And this is basically based on report of a parent. So questions asked because the child can't really do much. So if the child is not able to do much, parents are asked, is your child able to do this or that? Or so it's kind of an adaptive scale. And based on that, an IQ number is given. So it's not entirely the most accurate. So sometimes kids can be given lower scores on adaptive scales. And then when they're a bit older, they can do actual objective testing. So why does it happen? And what are the risk factors? In 50% of cases, you can find out a reason, okay? In 50%, you can't. You've done all the investigations possible and there's just no reason, okay? That's historically, but currently, just because of the new technology, in about 70% of cases, you can figure out why. And the most common cause, obviously, is congenital syndromes, right? So genetic differences, things like inborn errors of metabolism, will kind of give you 40 to 50% of cases. So these genetic problems. Environmental and exposure to toxins, like fetal alcohol syndrome, okay, or that will give you around 10% of cases. Pregnancy and perinatal problems like trauma, prematurity, hypoxia, that will give you around 10%. And then acquired medical conditions, epilepsy, head injury, brain tumors will go under that. But the majority is more genetic. Okay, we're still studying risk factors, but the low birth weight was seen as the strongest predictor of having a disability. So prematurity and low birth weight. Males that are born to Black, Asian, and Hispanic women and older women. Lower levels of maternal education, lower socioeconomic status, multiple births, second or later born children. So these were seen as risk factors. Okay. This is FYI, all right, on genetic and molecular basis. This is really very complex. So it's really what the slide is about is just how there's such an advance in looking at, genetic studies, like looking at the whole exome and the sequencing and the genome. So it's really complicated. Okay, and so we do these assessments, and obviously, they're done by the neurologists or the geneticists. Okay, So intellectual disability and neurodevelopmental and neuropsych disorders are caused by variations in the genetic control of brain development, maturation, and function from the fetal period onwards, okay? And so all these sort of alterations in signaling and metabolic pathways, proliferation, migration, so it's super complicated, okay? Outcome is you have a child with intellectual disability and you're kind of trying to work backwards. That's what happens. They present with, you know, intellectual disability and it's like go fish, try to find out why. And so you start there and you work backwards trying to find out why this child has the problem that they have. Okay. I do want you to know the syndromes, okay? I'm going to skip this one because, again, it's not a very common, we don't see it, but the ones to follow. So let's skip this slide, the deletion syndrome, I'm not going to ask you about. But this one, the DiGeorge syndrome, because it's really the most common survivable interstitial deletion in humans. Okay, so we do see these kids in the clinic. Okay, it's one of the most common causes. It carries the highest genetic risk for developing schizophrenia, so it's really relevant to mental health. Also associated with ADHD and autism spectrum, the prevalence of about 1 in 2,000 to 4,000. Many will actually have mild intellectual disability and may go undiagnosed. Again, it depends on the school system. So I've seen kids, I have patients who are, really upper range, mild intellectual disability. So if we say that it's around, up to around 70. So, somebody with an IQ of 69, it's kind of, it's almost like they're spilling over into borderline IQ, which are the slow learners, okay? So I have this patient who's now actually studying in college, but they're studying translation because his English is perfect. And he's somebody who's in that range. And I'm not saying he has DiGeorge syndrome. I'm just saying that these kids with just upper mild intellectual disability can pass undiagnosed, okay? With DiGeorge, they have defects in the neural crest development. And so they have complications like cardiac anomalies, palatal anomalies, some kind of immune deficiencies, developmental delays. Average IQ around 70. So 70, again, you're talking about like right in between mild and borderline. But they have a larger split between their verbal and nonverbal. So if you're going to do the Wixler for these kids, their verbal skills are going to be much higher than their performance, okay? And their speech difficulties may be related to their craniofacial. So people who have cleft palate or cleft lip, obviously going to have language issues, speech problems because of these craniofacial deficiencies. Okay, so this one we have to know. Angelman syndrome also, because it's one of the differential diagnoses with autism spectrum. So their rate of about 1 in 12 to 20,000. The prevalence in populations with severe, intellectual disability is about 1.4%. Their characteristic features become prominent in toddlerhood, okay? And these are severe speech impairment, inattention, gait ataxia, frequent laughter. So this is kind of the hallmark. So these are kind of smiley, happy kids. That's how they present because they have this they have these inappropriate laughter, very excitable, okay, with hand flying. Hyperactivity and sleep difficulties are common. Delayed head growth causing microcephaly by age 2. Seizures are common before age 3. And so these are kids that will end up in your office as a pediatric neurologist because of their seizures, because of their microcephaly, because of their gait ataxia, okay? Also, certain anticonvulsants are contraindicated and may cause seizure exacerbation. So they may be of the more difficult kids to treat who have a seizure disorder. And so they have also altered the dopaminergic metabolism. So antipsychotics have to be used with caution. Important also for us to know because, often children who come in with behavioral problems, inappropriate laughter, you want to start them on risperidone. Okay, so that's kind of the first thing you want to do, but you have to be careful because, again, because of the altered metabolism, so they're more susceptible to side effects. So maybe you would not use an antipsychotic with these kids. Obviously, Down syndrome, I'm sure you've all seen, maybe not seen as many Angelin, but for sure trisomy. So 1 in 1,000 live-born births, it's the most common genetic cause of intellectual disability. And we know that it's because of, on chromosome 21, there is this triplicate state, most commonly caused by errors of meiosis, maternal origin increasing with maternal age. Okay, so the phenotype is characterized by more than 80 features, average IQs around 50. They have a very distinctive cognitive profile. They have very good strengths in visual processing, but significant language impairment. Strengths in social skills relative to communication. They could have issues with executive function, so we do see ADHD. And then they have cellular findings that could be associated with Alzheimer's at an early age. So these are high risk for developing Alzheimer's earlier on. Fetal alcohol syndrome or spectrum. Okay, so the rate is about 1% of live births. Intellectual disability is a hallmark. There is a very distinct pattern of facial anomalies and CNS abnormalities. Again, if you're a pediatrician, neurologist, you would see these kids. With neuroimaging, they have an abnormal brain size and shape with the cerebellum and ventricular size. With the corpus callosum, again, developmental problems. They have verbal and non-verbal learning deficiencies, attentional issues and impairments in executive function. So they would present with ADHD. So that's how we come across these kids. Or that's our sort of point of contact, is because of their attentional problems. Fragile X is another really important syndrome, okay? So it is a complex change in the X-linked gene, okay? It's kind of like a pre-mutation status. It causes this Fragile X-associated tremor ataxia syndrome, okay? It's the leading cause of intellectual disability with males in the moderate range and females in the mild range. When we have kids come in with autism spectrum, okay, we have to screen them from Fragile X. So it's one of the sort of screening tests because 25% of these kids will meet criteria. The incidence is more in females. And they have a very specific neurocognitive profile of hyperarousal, hyperactivity, social anxiety, and shyness. They're at increased risk of schizotypal disorders, which you guys have already sort of studied. So the psychosis, schizo kind of affective disorders, ADHD and autism spectrum. Okay, so we can see them earlier on in life because of ADHD and autism, and maybe later on in life because of psychosis. Rett syndrome, another really interesting one. Okay. Majority of patients are female. So Rett's was previously in DSM under the autism spectrum disorder, okay? And it was just out in DSM-5 was moved out. Mutation in males is presumed lethal. Okay, so that's why we see it more in females, because in males it causes this encephalopathy that's fatal. A prevalence of 1 in 8,500. One of the most causes of severe intellectual disability in females. What's very, let's say, classic or pathognomonic is that there's this regression that happens where they have normal development in the first up to a year and a half. Then they have a rapid loss of function, intellectual, as well as fine and gross motor skills. And they develop these very characteristic hand wringing movements. So it's kind of like their hands start to kind of have this very interesting movement, and 90% of them will have seizures, and sudden death is caused by prolonged QTC. Okay, probably in my practice, I may have seen like 2 or 3 of these kids. They're not common at all. Prader-Willi is another really important one. It's caused by paternal deletion in 70% of cases, or maternal disomy in 29%. So it's a chromosome 15 kind of problem, 1 in 29,500, with global developmental delay, failure to thrive in infancy, giving way to hyperphagia, okay, obesity, hypogonadism, short stature, and behavioral problems. So it's kind of like a triad. Okay, so these kids end up in bariatric clinics because of their obesity. So it's like this uncontrollable eating. So I remember seeing a 2-year-old, okay, with Prader-Willi, with a BMI of, I think it was like close to 30. Okay, so poor little girl. It was just, you know, what do you do with these kids? You know, another one that I saw at the age of 9 with a BMI of 35, who really had to go to bariatric surgery. But again, I wish the chat was working, but one of the main issues or concerns with these kids is what? So they have hyperphagia as part of their syndrome. Then you do a sleeve or bypass or whatever. What is the likelihood of complications? Because these kids are going to eat and so they're going to leak. Okay, so it's really, really hard because again, there is a level of intellectual disability that's usually mild, but it's really hard for them to understand that they cannot eat, because if they do, they will, you know, have a complication. They have compulsive food seeking and hoarding associated with anxiety and mood symptoms. Okay, and we do use medications to help reduce self-injurious behavior and mood. But again, we have to be very careful because antipsychotics that could be used to reduce self-injurious behavior will make their appetite worse. And so, you know, when you're assessing a child, I mean, obesity and weight is one of the essential parameters that we have to look at, because there's no point in reducing their aggression and then, you know, making them put on weight and putting them at risk for diabetes. Okay. So the developmental course and prognosis really varies depending on etiology, severity, and the underlying medical condition. You have to pay attention to making a diagnosis, treating any functional or physiological barriers to the skill acquisition. So if there is, you know, speech issues, hearing problems, so these are functional, you know, to see if you can improve that, to improve their skill acquisition. Like I said, these craniofacial abnormalities will impair speech and language development. So, you know, usually these kids will get surgery. How do you evaluate? So the clinical history is beyond essential, cytogenic diagnostic testing, metabolic testing, and then neuroimaging. So it's very comprehensive, all right? So using MRIs and EEGs, again, depending on what it is that you're looking for, but the psychological assessment, so the IQ assessment is part of your history and physical exam. You must get an assessment or evaluation of their cognition. So comorbidities in about 30 to 50% of cases will have other problems. So emotional and behavioral problems are 3 to 7 times higher in this population than in typically developing children. So this population of kids with intellectual disability is really a challenge to, you know, pediatric neurology, child psychiatry, because of their behavioral and emotional problems. Again, mental health conditions will manifest differently in this population, specifically mood disorders, because they're not going to tell you that they're sad. They're not going to tell you that they want to kill themselves. They will behaviorally act upon it. There was this one kid I was seeing, and so what they noticed is he's around 13, intellectually disabled. And I think, I mean, he looks dysmorphic. I'm not sure what the syndrome is, but they noticed that he was sleeping, you know, his sleep was affected. His appetite was not the same. He seemed more irritable. Okay. That's pretty much all they noticed. And then one day Doc goes in and he finds that this kid has strangled himself with a belt or like a rope or something. Very quiet, like he's not very like behaviorally disinhibited or anything, but you know, that's how they brought him to my clinic, is, you know, they found him trying to kill himself. And he's not expressive, you know, but all they noticed was just all these changes in his sleep and appetite and energy. Okay, so that's pretty much all it takes. Symptom detection is difficult because of cognition and communication skills. You have to consider medical conditions when there's a behavioral issue. So like the girl I told you yesterday, so it's been a year of disorganized behavior, sleep, hallucinations. So we have to consider epilepsy as one of the reasons for why this child is behaving this way, or some kind of autoimmune problem. Okay, so that would be the priority to investigate. Okay, so there's an increased risk of comorbidity because of the disability, because they have lower adaptive functioning, because of their language impairment, lower socioeconomic status. And then if you have families with just a single parent, then we have a problem. So is there a treatment for these kids, right? So prenatal diagnostic testing, newborn metabolic screening, so these are all important. Folic acid supplementation. There is no treatment for intellectual disability, okay? It's very much integrative. You're looking at their developmental level. You look at their trying to improve their skills, improving their behavior, and then the psychotherapeutic things depend on their intellectual level. So social skills training, possible parent training programs. Okay, so this is again FYI, and I'm sure you've taken this already and psychopharm, but with this particular population, you know, absolutely start low and go slow, such as with the elderly. About a third of people with intellectual disability are receiving at least one, if not more. Okay, like I said, risperidone is the most commonly prescribed, and one of the reasons it's the most commonly prescribed is because it comes in liquid form. And so it's really hard for these kids to swallow pills, whereas much easier for them to, you know, take a liquid. Problem with weight gain. They're usually on anticonvulsants. We could give them antidepressants for repetitive behaviors, okay? They could take alpha-2 agonists for impulsivity and aggression. Sometimes we use stimulants. Things like naltrexone for self-injurious behavior, not very conclusive results. We love melatonin for sleep disturbances. Okay, educational and community service. So there has to be a specialized educational plan for this child, and it's usually multidisciplinary. Early intervention, absolutely necessary. You have to have services in multiple settings. Like I said, individual educational plans, resource rooms, and then support, obviously, to the family to prevent burnout. So it's a very multidisciplinary approach to these kids. But again, the take-home message is that there is no treatment. These kids will live with their disability, but we want to focus on their strengths to improve as much as we can. And the earlier you intervene, the better. So again, this is a summary. About 50% of these cases are not known etiology. Their development can be as normal as that of normal children. The clinical evaluation is really very comprehensive. Youth with intellectual disability are very high risk for mental health problems. Treatment is integrative. And again, behavioral intervention and psychopharm have the best evidence base. All right, thank you all. I will see you next Thursday, inshallah. I'm gonna let you know next Thursday about like what lectures we're gonna, you know, delete. I think we have 4 or 5 left, so maybe we'll just end up taking 3 and not doing the last 2. But I will just confirm with you next week. Like I said, unfortunate that there's no chat. I really enjoy the back and forth with you guys. You're very insightful. You have really amazing comments. Hopefully next time we'll see. I'll check with Mr. Muntasir and you know what the problem is with the chat box. And if you have questions, please, like I said, just try to kind of accumulate them if possible. And you know, I'm not saying just one email, but you know, not 180 emails. Okay. Thank you so much. Have a great weekend.
Thank you, doctor.
Thanks.